tonight. Hello, good morning. My name is Oluwadamilola Jalayemi, and I'm presenting on the study preparing for long-acting injectable antiretroviral therapy for treatment in Los Angeles. I'm a program coordinator at a UCLA Center for HIV Identification, Prevention, and Treatment Services, CHIPS, and I had a great opportunity to work with an amazing study team on this Ending the HIV Epidemic Supplement project. And on this slide, there's a list of all study team members, and I'll be sharing acknowledgements and collaborators at the end of my presentation. Just a brief overview. The current known HIV treatment is daily oral antiretroviral therapy, which has been shown to dramatically reduce the morbidity and mortality associated with HIV infection and the transmission of HIV to sexual partners. As we all know, undetectables equals to untransmittable, U equals U. Long-acting injectable for HIV treatment, also known as LAI for HIV treatment or LAI for antiretroviral therapy for HIV, is an innovative and promising new treatment advancement for HIV, which has just received regulatory approvals in the United States this month, January 2021. The treatment comes in the form of 2 injections administered monthly, and could potentially be administered every 2 months, pending approvals. It is important to note that although this treatment is promising and advantageous, it also has the potential to burden healthcare systems due to the increased clinic visits. There is also an eligibility requirement to be virally suppressed prior to the initiation of long-acting injectable antiretroviral therapy for HIV, which could cause gaps in access and pose a potential barrier, especially for vulnerable communities and communities that are dealing with structural and psychosocial barriers. The study team proposed 3 main aims for this study. The first aim is to strengthen and develop partnership and build capacity in partners to support research on implementation of long-acting injectable antiretroviral therapy for HIV as part of a strategy to optimize viral suppression in Los Angeles County. The second aim was to assess the policy systems, financial, operational, and clinical level barriers to and facilitators of the rollout and scale-up of long-acting injectable antiretroviral therapy for HIV in Los Angeles County. The third aim is to assess the end user, which is the consumer's perceived barriers to and facilitators of long-acting injectable antiretroviral therapy treatment use in Los Angeles County. I'm going to go ahead and share some of the methods that we use in this qualitative study. We conducted 5 focus groups / semi-structured interview in February of 2020. 2 of the focus groups were consumer focus groups only. 1 was with clinical providers, 1 was with clinical and non-clinical providers, and 1 was a semi-structured interview with a non-clinical provider. It was originally scheduled to be a focus group, but ended up being a semi-structured interview because only 1 participant showed up. Overall, we enrolled 18 consumer stakeholders and 23 clinical and non-clinical stakeholders. And these sessions were conducted at 3 locations in Los Angeles County. We had a diverse range of participants, and on this slide, you see the characteristics of participants in terms of age, gender, sexual orientation, race, and ethnicity. On the left side, we have the consumer participant demographics, and on the right side, is the clinical and non-clinical participant demographics. I'm going to go ahead and share some of our findings. General perspectives. Overall, there was enthusiasm and acceptance for long-acting injectable antiretroviral therapy for HIV as a new treatment option. It was cited as a new tool in the toolbox of HIV treatment options. I'm going to go ahead and share this quote from some of the participants. Well, I think it's a positive contributor to our materials to treat our patients. It's not going to be with every patient, but there will be patients that it will be their ideal treatment. This is from a clinical stakeholder. I think that would be so awesome when that gets approved. Because for me, I would prefer to do a long-acting injectable instead of having to take a pill every day. This is from a consumer's perspective. I'm going to go ahead and share some of the consumer level considerations, organizational level considerations, and messaging recommendations, as well as implementation recommendations that we received from participants during the cause of this study. In terms of the key considerations for implementation on the consumer level, several themes emerge as key considerations for implementation on the consumer level. Adherence was a key facilitator noted among the participants. Participants expressed the long-acting injectable antiretroviral therapy will be helpful for those who tend to forget taking their treatment pills. Participants expressed that it might be easier to adhere to long-acting injectable antiretroviral therapy for HIV than the daily oral antiretroviral therapy, especially due to a reduced consumer responsibility around treatment management. Although LAI antiretroviral therapy for HIV was credited by consumers to potentially reduce treatment management burden, especially in offering relief from pill fatigue and reducing anxiety, the more frequent hospital visits required for treatment might pose a significant barrier to adoption. Participants also expressed concerns around resistance, especially for consumers who are unable to make it to their required monthly or every other month clinic visits. Stigma was a major facilitator with long-acting injectable, and it was cited as having the potential to reduce internalized and social stigma, resulting from the daily reminder of being sick while using the antiretroviral therapy daily pills, or from people finding out about the medication. However, consumers noted that there might be a risk of stigma with increased clinic visits within hospitals or clinics. Medical mistrust was a very important barrier stated by consumers, especially for Black communities that have faced a history of discrimination, systemic racism, and negative healthcare experiences. And it's an important consideration that has to be taken into account during the implementation process of long-acting injectable treatment for HIV. Also, fear of pain at the site of injection and expected side effects was expressed as a major barrier as well. And comfort with shots was seen as relative, as those who are more comfortable taking shots might be more acceptable of taking long-acting injectable antiretroviral therapy, while those who are not comfortable with shots may not opt for taking the medication. I'm going to share some illustrative quotes here. In terms of stigma, a lot of patients we find just the daily routine of taking a pill every day is a reminder that they are ill. And I think the injectable has an option to take that stigma away, or at least take that personal internal stigma away from those people living with HIV who kind of feel that burden. Another quote here on medical mistrust from a consumer perspective. That is actually a huge theme in the Black community, mistrust or a lack of trust in the healthcare field. So that could definitely be an issue that could get in the way. I'm going to go ahead and move into the key considerations for implementation on the organizational level. Financial concerns, specifically around insurance coverage and payment for staff who were delivering LAI antiretroviral therapy for HIV, was expressed by participants as key considerations. Staffing needed in terms of capacity to respond to increased consumer volume and other responsibilities related to consumer influx, such as managing missed appointment and other tasks, was an important consideration. In addition, storage of LAI antiretroviral therapy for HIV and the physical space to actually deliver the medication was also expressed as a potential barrier to implementation. Lastly, and importantly, provider and staff preparedness was highlighted as a major implementation recommendation from participants. Participants expressed the need for information, clinical guidelines, protocols, and guidelines around determining the ideal patient for treatment and referral for HIV treatment using long-acting injectable antiretroviral therapy. I'm going to go ahead and share some illustrative quotes. Provider preparedness, a non-clinical stakeholder stated, I think implementing the program for injectables of HIV clinics has to be very well thought in regards to training and capacity building, not only from the clinic administration, but also from the persons dispensing and applying the medications. In regards to staff capacity, you're talking about an influx, actually, of new visits potentially. Whether our clinics can handle that, whether we have the staffing. This is a concern from a non-clinical stakeholder. In regards to key recommendations for messaging and implementation, participants shared some ideas. Community engagement was highlighted. Messaging from a community perspective and by the community is key. Participants generally felt that consumers of long-acting injectable antiretroviral therapy would be the best people to deliver public promotion of long-acting antiretroviral therapy for HIV treatment. They expressed that medical professionals should deliver the scientific information, while consumer voices should be at the center of long-acting injectable antiretroviral therapy for HIV promotional campaigns. Participants emphasized that community engagement will be critical for effective message development and implementation, and for establishing buy-in and reducing mistrust of long-acting injectable antiretroviral therapy among priority populations. Other messaging recommendations suggested include using avenues such as television advertisements, billboards, social media, and other avenues to get the information out. In regards to, this is a quote here for messaging. The peer-to-peer strategy, I think, it is incredibly effective, particularly when using people within a community. You tell them, hey, we've got this. Could you talk to your friends and stuff about it? I think when they're the ones to push the message, especially for people of color, then it's a little more digestible. This is from a non-clinical stakeholder. In terms of implementation recommendations, there were 4 key areas. Participants recommended that other staff be allowed to deliver long-acting injectables, such as nurses, pharmacists, and medical assistants, and to also expand the sites of delivery to include pharmacies and other points of care. Also recommended was treatment education, including peer navigators, support groups, and other support services to encourage adherence to medication and treatment for HIV. It was also suggested that research trials and demonstration projects, including pilot studies to ensure that clinics and organizations are ready and adequately equipped to handle the implementation of long-acting injectable antiretroviral therapy, and also clinical research to expand the eligibility criteria for those who were not initially included in the clinical trials was recommended. Participants also recommended the possibility of implementing innovative strategies such as self-injection and learning from other similar injection therapies, and possibly providing more options for administering this medication to include other anatomical sites, especially for those who might not be able to take injections in the buttocks, such as those people who may have implants. I'm going to go ahead and share some recommended steps that were put together by the study team. Addressing the barriers and capitalizing on the facilitators from this study are important next steps. In terms of partnership building, all HIV stakeholders need to build relationships and develop partnerships that will support the implementation of long-acting injectable antiretroviral therapy through the development of innovative research ideas. Establishing similar systems on the organization level within HIV service delivery organizations prior to LAI implementation is important. Service organizations, especially HIV care clinics, should perform detailed analysis of their capacity and discuss their current financial, physical, and staff capabilities. Determine the training and capacity needs of the organization. Create a budget to reflect the potential costs associated with implementing long-acting injectable antiretroviral therapy for HIV, and outline the necessary steps needed to increase capacity and funding. Furthermore, establishing policies and standardized treatment guidelines are important. Provider training and education is extremely important, as providers need to be equipped in order to easily discuss long-acting injectable antiretroviral therapy with their patients. Standardized guidelines will be helpful for clinics and providers to make guided treatment recommendations for consumers. Also, developing policy to guide the success of long-acting injectable antiretroviral therapy by addressing access to health insurance coverage, securing pre-approvals of health insurance coverage within policies to ensure that the medication is affordable, and to include long-acting injectable antiretroviral therapy in insurance formularies is important to the implementation, the successful implementation of this treatment in Los Angeles County. As previously mentioned also, research pilot projects and clinical trials are important to ensure that health systems can handle the implementation of long-acting injectable antiretroviral therapy, and also to improve eligibility criteria for those who would really benefit from the new treatment options, respectively. Consumer engagement and consumer treatment education are important considerations. To begin from the community when developing plans and working with the community to ensure that they are at the forefront of messaging for the communities. Consumers are the key to ensuring that we address issues with trust. Also, addressing medical mistrust is an important consideration that was highlighted in terms of implementation of long-acting injectable antiretroviral therapy for HIV. And it could be addressed on the clinical level through psychosocial training for providers, and also engaging communities in discussions about substance of mistrust. I believe these are all the recommendations that we have. I'm going to go ahead and acknowledge our project collaborators. I want to go ahead and acknowledge our collaborators. I want to thank the LA County DHSP for their involvement from the inception of this project all the way up until the end. Also, our study team members were scientists from RAND Corporation in UCLA who proposed this project and ensured its success. And also want to thank the CHIPS Community Advisory Board members for their feedback and involvement in this process from the beginning all the way to the end of this project. We also want to thank our amazing studies participants from within the Los Angeles communities and our various partner organizations. I would also like to acknowledge our funding source, which is the National Institute of Mental Health, for providing the funds that supported the study. Thank you for listening, and any questions?